good morning. Uh, I hear Dr. Tom has some other issues to deal with this morning. So, can you guys hear me? I'd like to introduce the speaker today, who is a speaker for rheumatology. Our invited speaker today is Dr. George Tsokos, who is a chief of rheumatology at Beth Israel Deaconess Medical Center in Boston. Dr. Tsokos is a native of Greece, graduated from the University of Athens, where all knowledge started, as you might know, many thousands of years ago. And he's fluent in Greek, so if you want to check him out, this is the time. He came to the United States in 1979 to work at NIH. And from NIH, he moved to the Uniform Services University. He's a colonel of the U.S. Army, where he started doing research on lupus back at NIH. He published seminal papers even back at that time, implicated Epstein-Barr virus in the causation of lupus. Then he started to work on T-cell signaling at the Army Research Institute near in Bethesda, Maryland. He was there until 2006 when he moved to Beth Israel in Boston. His work has exploded since then, and he has become a leader of the field of lupus research. He is probably the foremost investigator of lupus. Uh, he works on everything: T-cell signaling, gene expression, spatial transcriptomics, organ damage. His papers have been published in top journals, including New England Journal of Medicine, Nature Immunology. Every year he has 4 or 5 papers in this top journal. He's extremely productive. He has received many awards. American College of Rheumatology, from the Arthritis Foundation, organizations. So I don't want to take too much more time. You have his name, and he can look him up in Wikipedia and Google. But it's my unique pleasure to have him here today. And briefly, I'd like to mention that after this, we also have a rheumatology grand rounds, if you're interested, which will be more research oriented. Thank you, Dr. Stoker.
Thank you. Thank you very much, Andres. That was very kind and generous of you. And it's good to be introduced by a close friend, right? I mean, never hurts. And I'm impressed that you start run rounds at 7 o'clock. I mean, we start at 8, but I guess you have food here, and that's a good reason to come. So, what I decided today is to, after a short introduction, on clinical pathogenetic heterogeneity of the disease, you all know about that. I'll share with you some concepts on pathogenesis of lupus nephritis and how this helps generate novel markers and treatment approaches. Um, some efforts to introduce precision medicine in lupus. Then I'll talk briefly about major problem in lupus, that is infections, because people die from infections, and some novel treatment approaches that and I will limit myself to low dose IL-2 and CAR T cells, so small things. These are my disclosures. You all know by now that lupus is clinically a very heterogeneous disease. You see here a collage of manifestations put together by my friend Richard Ferry. All I want to point out is, and brag about, that this lady here was a patient of mine when I was a fellow, approximately 350 years ago. And you see that rashes manifest only in sun-exposed areas, indicative of photosensitivity. You see here the numbers of how many people have lupus in the United States, that they're women. People who are Black or Hispanic suffer more disease, worse disease, and worse organ damage. People attribute that to socioeconomic parameters and everything, but I happen to disagree with that, and I think these are the reasons are far beyond that. It's due to post-traumatic stress, but this is a talk for another area, and definitely not during these years. Uh, this is just a way of looking at lupus, and actually all other rheumatic diseases and probably other diseases. There are a bunch of factors up there. You see them at the top, uh, genetic, environmental, and so on. But in each patient will act either serially or simultaneously to produce a number of what I call common effectors of the immune response, which is immune complexes, antibodies, cytokines, and T cells, which will go around and visit different organs, will visit the kidney, the skin, and so on. But as you know, not all patients have the same manifestations. So, and the reason for that is that there are additional, still unrecognized local factors which determine which organ will be damaged and which will not. And I'll come back to that. The message here is no organ will suffer damage unless the organ grants a visa to the inflammatory response. Uh, we have we have been studying what is going on inside the T cells, as Andres mentioned, and in many ways we work in parallel with what Andres is doing here, trying to understand why immune cells behave the way they behave in patients with lupus. Not gonna belabor and get you through the details of that, but in doing so, Andres and I have identified molecules that have been picked up by pharma and have been studied in clinical trials. Uh, all I want to mention from that is this, and I have a reason for that. There is a kinase, it's a calcium calmodulin kinase 4, which phosphorylates a transcription factor known as CREM, cyclic response element modulator, which over the years, and you can see here the top leaders of this research in my lab, lots of effort, figured out that this pathway alone is responsible for the opposite production of two important cytokines. One of them is interleukin 2, which is very important for the homeostasis of the immune system, and the other one is IL-17, which is pro-inflammatory and contributes to organ inflammation. So this pathway is directly responsible for the opposite production of this. And that's what the previous studies have shown, right? And I'll get you right to the end and spare you all the details and the pain that we went through in identifying that. Now, I will discuss briefly with you the importance of immune and local factors in the expression of kidney injury and some concepts of organ tolerance. You all know about immune tolerance, right? That when the immune system faces antigens, will respond to some, selectively not respond to others, known as immune tolerance. But here I'll tell you about organ tolerance. Now, I'll start with this case here, which was put together by my young colleague, Ria Barkova. Is a 10-year-old woman with family history of autoimmunity, had ANA and phospholipid antibodies, anemia, serocytes, and all this. And back in 2006, she was diagnosed as having lupus. Over the years, what is that work? Did it work now? I should stick with this. Okay. Well, I have to come closer to that. Can you hear me? Or if you want to hear me, can you hear me? All right. The first question is, do you want to hear me? Right. So over the years, he was treated with hydroxychloroquine, mycophenolate, azathioprine, steroids, methotrexate, and belimumab, and all the goodies that we have. In 2017, she was found to have double-stranded antibodies, right? And then in 2020, she presented with leg edema, nephritic urine sediment, RBC cuts, and renal biopsy was done. I want you to keep in mind for the time being these two dates, 2006, 2017, and 2020. I'll come back to that in a moment. So a kidney biopsy was done by my friend Isaac Stillman, who unfortunately left us, went to Mount Sinai. And you can see on over here, there is endocapillary proliferation, podocyte damage and death, and what nephropathologists call stage 4 glomerulonephritis. Immunofluorescence, revealed the position of immunoglobulin C3 and everything else you look for, what the nephropathologists call full house. And EM, we see immune complex deposits, subendothelial and mesangial capillaries. Now, it was important here to look at the interstitium. Most nephrologists and most rheumatologists forget that the kidney has an interstitium also. And what you can see here, immune cell infiltration. These are T cells and B cells. Many of them are double negative cells, I say, don't have CD4 or CD8, and many of them produce inflammatory cytokines like IL-17 and so on. And their formation is very important because it predicts the survival of the kidney. Interstitial inflammation on its own predicts alone how long kidney function is going to survive. All right, so the reason I asked you to remember these 3 dates is because there's few questions that arise that are unanswered. When did the kidney start getting involved? In 2017, when the double negative stranded antibody titers were high, would she have had options for early treatment if we were able to detect nephritis before clinical symptoms? How can we follow response to treatment considering that kidney biopsy is not an easy thing, has complications, and on top of that, it's very difficult to convince patients to have a follow-up biopsy so you can adjust the treatment. So what prompted the involvement of kidneys, and could the involvement of kidneys have been predicted when she was 10 years old? Right at the beginning. Right. Kunihiro, when he a nephrologist, he was in the lab. He heard everything about CAMK4 being studied in T cells, where I showed you earlier, and took a few slides from kidney biopsies and stained for CAMK4. And to our surprise, we found that podocytes in the kidney of patients with lupus nephritis had CAMK4. So it was a molecular link, we thought, between T cells and podocytes that was upregulated. Ria Barkova, another nephrologist in the lab, expanded this and studied more patients, and we referred for suspicion of lupus nephritis, and she did all the statistical analysis that people do and found that CAMK4 was indeed upregulated in podocytes, so patients with active lupus nephritis. So obviously, you cannot do too much with humans, right? You cannot breed them at will. You cannot modify molecules still. So you go to the mice. That's what we do always. We start with humans, we go to the mice. And you can see here that this mouse, MRL-LPR mouse, that's prone to lupus, develops lupus quite early. He has CAMK4 in podocytes. So that was a bonanza because now we could start manipulating this mouse. This is a podocyte. You see the EM picture here taken by Maria. And you can see the podocyte, and podo means foot, as you know, in Greek. And you see its feet touching the membrane nicely here. This is a cartoon over here of the podocyte that I made. And what we found that increased levels of CAMK4 now in cultured podocytes or in podocytes isolated from glomeruli of lupus mice, when it's upregulated, it forces the expression of two molecules, CD80 and CD86, which we immunologists know as co-stimulatory, but nephrologists know them as damage molecules. And on top of that, it suppresses the expression of nephrin. And nephrin, is the simplest way to describe, is a zip protein that connects the feet of the podocytes, so it doesn't allow protein to filter. So it's important for filtration. Now, in these podocytes, if you inhibit CAMK4 or you silence it, all this reverses and nephrin expression comes back. These are the molecular mechanisms. Each of these papers is approximately 100 panels. I'm not going to get you through these, except for to tell you over here, Keyahu showed that CAMK4 phosphorylates this protein, which is a scaffold protein, 1433, And as soon as synaptopodin is released from the scaffold, it's degraded. Synaptopodin is very important for the structure of the podocytes, right? So as soon as synaptopodin is gone, podocytes become a little bit, not happy. Rhea, through other studies, she found that it actively represses the transcription of nephrin. So in the presence of CAMK4, podocytes lose a structural molecule and now what Rio found here is in subsequent studies working with Richard Cummins, who was upstairs, he runs the glycomic score, is that it's the glycosylation of immunoglobulin that causes podocyte injury through the upregulation of CAMK4. So in brief, what she found is that lupus nephritis, IgG, does not have this galactose here. It has a fucose, but it doesn't have. If you take away the fucose, the immunoglobulin, the lupus nephritis immunoglobulin cannot be sort of podocytopathic. Now, interestingly, and for mechanistic studies, when she took away galactose from normal immunoglobulin, that immunoglobulin became sort of podocytopathic. So, right, very important. Now, this questions the classical dogma that anti-DNA antibodies cause lupus nephritis or involve in pathogenesis. Here it says it's the glycosylation of immunoglobulin rather than. Now, there are more studies that Ria is doing, is about to submit a paper to show how I still have problems. Oh, all right. All right. It's better now? Okay. Oh, my God. Yeah. All right. Yeah, thank you. Yeah. All right. Thank you. So it is important here to think about the importance of other DNA specificity that we rheumatologists for now more than 60 years been claiming that causes lupus or is involved in lupus nephritis. Now, at some point, and several years ago, we made this mouse. We deleted CAMK4 from all the cells in this lupus-prone mouse, MRL-LPR. And you can see the mouse that doesn't have CAMK4, it has much less glomerulonephritis, less immunoglobulin deposition, and so on. But more importantly, when Kunihiro isolated messenger cells from this mouse, these messenger cells did not proliferate, and these messenger cells did not produce IL-6, even when she stimulated with platelet-derived growth factor. And that is important because IL-6 had been shown earlier on its own can lead to glomerulonephritis even in normal mice. So CAMK4, if messenger cells don't have CAMK4, they will not proliferate and they will not produce IL-6. And that is for messenger cells. Now, I'll summarize a lot of work in these slides. And just to make my point that every organ to suffer inflammation has to grant license to inflammatory response. Right. Of course, we have the immune system, we have the T cells with the aberrant opposite production of these two cytokines. We have B cells producing immunoglobulin. IL-23 is produced by a number of cells. Oops. And the kidney parenchymal cells, they upregulate CAMK4, and they express also IL-23 receptor. I already told you that messenger cells, if they don't have CAMK4, they don't proliferate. What we found is when we take CAMK4 away from podocytes, right, only from podocytes, then the mouse does not develop glomerulonephritis, no matter what is going on in the periphery. We have other data now about to be published that if podocytes don't have IL-23 receptor, only podocytes, right, in a specific one, the mouse does not develop glomerulonephritis, despite the fact that there is autoimmune response in the periphery. And in other data, lupus mice that don't have IL-23 receptor in the epithelial cells, they don't develop interstitial inflammation. So and this is clinically relevant because you have people out there who have anti-DNA antibodies, have NA, they don't get glomerulonephritis. I suspect that these people cannot upregulate CAMT4, cannot upregulate IL-23, and if I can speak prophetically, many other molecules down the road to be discovered, right? So now will bring me back to the slide I showed you about the pathogenesis of the disease. I showed you that all these factors here contribute to altering immune cell function. And each group of these factors have been claimed in the literature to alter immune cell function. What has been ignored and not touted enough is that each factor is affecting the function of other factors, like epigenetics affects the function of genes, environment, and so on and so on. So there is a huge interactive process down here. Now, these cells are stimulated or the function is altered, and they go on and they visit organs. Now, given what I showed you in the previous few slides, there are an equal number of factors, again, the same ones, genetic, epigenetic, environmental, and so on, which interact among themselves and alter the expression of molecules within parenchymal cells in the kidney and other organs. And all this has to be properly upregulated for the immune response to exercise inflammatory, to exercise inflammation. Right, a few thoughts about precision medicine, right? Classically, we talk about the right drug, the right dose, and the right person. I think the more important thing is to provide all this to the right cell, the right organ. And here is an orange with globes, and these are nanoparticles, lipids. Inside you put a drug, and these globes here represent an antibody to a target cell that you wish to deliver the drug. Right, and here's an experiment that was done by Keyaho and a number of other people in the lab. We constructed nanoparticles and we loaded them with an inhibitor of CAMT4. The name of the inhibitor is K93. We tagged them with first with CD4 antibodies and everything, but then lately we tagged it with antanephrine and antipodocin. Right. Nephrologists will tell me podocin is not expressed podocytes. That's wrong. If you injure podocytes, they express podocin the surface. So they're already injured, so express podocin. But anyway, nephrin is expressed. So what you can see here is when the mice are treated, this is the lupus-prone mouse, the MRL-LPR. You see here lupus nephritis with crescents and so on. If you treat them, you deliver a CAMT4 inhibitor only to podocytes, all pathology goes away, proteinuria goes away. Mind you, systemic autoimmunity is not affected at all. So this is what I would call precision medicine. There's been no patient coming to me, I don't know about you, Andres, telling me my T cells are sick. They come and tell you, I have hypertension, my legs are swollen, right? All right. Now, if you look at, and this is a beautiful slide, was prepared by Maria. It's my partner in life and crime, as they say. And you can see the untreated mouse, a lot of immune complex deposition here. And the treated mouse, you see the feet of the podocytes nicely touching the membrane and touching each other. I think this is spectacular. So, conclusion from all this is that if you are able to preserve the structure and the function of podocytes through the inhibition of CAMT4, in our case, immune complexes are not allowed to deposit, right? So the podocyte does not grant a visa or license. All right, let me go to my favorite topic here, why people with lupus die from infections. And I think Andres introducing me mentioned this experiment. This was my first joint immunology paper, Andres. a couple of years ago. Uh, what it what we did at that point is we tried to teach lupus T cells to kill or control self B cells that express EBV. You can see here that the lupus T cell would never learn how to contain EBV transfected B cells. At that point, we said, all right, EBV will transform, autoantibody producing cells will cause damage and everything. But here is very important. Later on, our friend Joe Kraft repeated this, and he showed that we were right. And CD8-specific cells against EBV are not properly functioning or proper in numbers in patients with lupus. I like to always ask what is the cause of morbidity and mortality in patients with lupus. It is infections, and the kind of infections people with lupus are opportunistic. Almost all, more or less the same one people with AIDS go to get, not in the same intensity, but it's always for us to, when we have a patient with fever and suspect infection, to consider all opportunistic animals. Why is that? Patients with SLE, despite the fact that have an enhanced autoimmune response, they're practically immunocompromised people. And treatment, the way we treat them with steroids and everything else doesn't help. And on the other side, infections feed the autoimmune response. Quite complicated. I asked Dr. Kunzler to review the literature and see if rate of infections over the years has changed. And since the first report of Darren Wallace in '85, this has not changed. This is practically a straight line, right? Different points have different numbers. Somebody else in the lab is revamping this to indicate how many numbers in each study was there. So again, not forgetting how we started, we revisited this issue. And it started like that. Sean Bradley was in the lab, did RNA-seq in T cell patients with lupus, and he found that the people who had the worst disease had a lot of CD38, right? What is CD38? You don't want to go into the chemistry. It's ectonucleotidase and destroys NAD, which is very important for many enzymes, right? And what Dr. Eric Kachiyama found is that the people with lupus had increased numbers and percentages of CD8 cells that express CD38 on the surface. And these people are the ones who suffered most of the infections. And this was a cross-sectional study with certain limitations. I'll come back to that in a moment. What she found is that the CD8 positive, CD38 high expressing cells had decreased ability to produce molecules that are responsible for the cytotoxic function. They don't produce perforin, enzyme B, and interferon, enzyme A here. And you can reverse that. And the reason for that, I mean, well, I don't intend to torture you here, is that CD38 positive cells, when she did ATAC, found that these molecules, granzyme A and B and everything, were closed, right? Loci were closed, and these molecules were not expressed. And you could reverse that very nicely. This is the molecular process. It's been published. I'm not going to get into that, but what it says simply that CD38 ectonucleotidase decreases NAD. NAD is very important for sirtuins. Sirtuins are deacetylases. One of the molecules that they deacetylate is this methyltransferase, and through that, it closes down the molecules that I said. All it matters, CD38 shuts down the cytotoxic machinery. That's the most important thing to remember. And to take that to a clinical level, more clinical level, is the studies that Pinmin Chen did in the lab. What he did is he took this other mouse that expresses lupus, the BXT2 mouse, and infected it with LCMV, lymphochoriomeningitis virus. If you do that in a normal mouse, nothing happens. he injected intraperitoneally, and all they get is liver disease if they get it. They don't get CNS. If you inject it intracranially, they get meningitis right there. But the BX2 mouse that had disease developed inflammation. You see here necrosis, periportal inflammation, and all the bad things. Young mice that still don't have disease, they 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 deal with the virus very nicely, almost like. But if disease develops, and it's so because the diseased mouse has more CD8, CD38 T cells. What did he do? He packaged a CD38 inhibitor into these nanoparticles. The gloves here are against CD8. So directed all this to CD8 cells. And as you can see here, the mice that were treated with nanoparticles that are loaded with a CD38 inhibitor, they don't have liver pathology anymore. And you see the control mice treated with empty nanoparticles or nothing. They have a lot of liver disease. And this is quite impressive. Obviously, a number of other molecular parameters change, but again, you can restore cytotoxic T cell function. Cytotoxicity is very important not only for fending off infections. Cytotoxicity is very important in controlling autoimmunity. Right? We are, well, early data is that we can prevent autoimmunity if you restore cytotoxic activity in lupus mice. Right? So it's very important to control. I showed you earlier cross-sectional study that lupus people who have lots of CD8, CD38 positive cells have infections. Here, Jose Rubio and Lama did a prospective study, and which we published in ACR Open. And you can see that the people who have over time CD38, CD8 cells, they're the ones who suffer infections. When they did this analysis here, it didn't relate really to disease activity. Did not relate to prednisone that they had taken, indicating that these high numbers of CD8, CD38 cells can be there and can be used as a biomarker to identify people who may develop infections and suffer morbidity and mortality eventually. So this is a prospective study, and I tend to believe prospective studies, cross-sectional studies are by nature not proving anything. All right, let's move on to current treatment approaches. And now I want to focus on these two that are trendy right now. There are lots of things going out there in lupus, lots of clinical trials, the best one producing a delta of 12, 13%. And if I may be cynical for a moment, if you study 1,000 patients, a 13% delta makes it statistically significant enough to convince FDA and help pharma make money. Low-dose IL-2. The immune system is all about balancing act. You have effector cells and you have regulatory cells, and you can see it up here. So the approaches and to people thought of approaches to expand or restore Treg function, which is universally accepted to be decreased in patients with lupus and many other autoimmune diseases. Amir Shorabi in this cartoon here, which I like, nicely portrayed all the efforts out there. One of them is low-dose IL-2. And it's because Tregs need IL-2 to grow and expand and function properly. They don't produce IL-2, but they need it. It is important to consider why low dose is because Treg cells are much more sensitive to IL-2 than effector cells. Effector cells have only the beta gamma. The IL-2 receptor is a trimer. I'm not going to bother you with all these details. Has alpha, beta, and gamma. Treg cells have the trimer. And when the trimer is there, you need very little IL-2 to bust to get a good response. Effector cells have only the beta and gamma, and you need a little bit more IL-2 to trigger them. And that's the reason for low-dose IL-2. It's like the quality, the structure of the receptor. People are trying to modify this IL-2 so they can expand its half-life. And also they're trying to increase its binding to the trimer rather than to the dimer. All sorts of lots of efforts out there. People have considered taking out Tregs from patients with lupus, expand them and reinfuse them. Later on, I'll talk to you about efforts to make CAR Treg cells. All sorts of efforts. People are creative. Why low-dose IL-2? Just a brief introduction. Clinical trials in lupus, usually they target one molecule that they heard it's important pathogens of lupus. But that molecule has not been demonstrated to be the driving molecule for all patients with lupus. May be true for a number of patients, but not for all of them. Now, low-dose IL-2 has a better chances because it stands higher in a number of pathways, because IL-2 empowers Tregs1, suppresses follicular helper cells that help B cells to produce antibodies, suppresses IL-17 production independently, and also shrinks this pool of double negative cells that my lab and Andres' lab have shown to be very pathogenic. So what Masamizo did is constructed an adenovirus to express low-dose IL-2 in lupus mice, and it showed that it could reverse pathology and autoimmunity. Now, people in China, as you may know, they published a number of studies, one of them in Nature Medicine, we don't have it here, and showed that IL-2 is very, very good in limiting disease activity in patients with lupus. The initial report was almost like miraculous, thaumaturgic. Subsequently, they decreased their enthusiasm. We'll see where it stands. Oh, that's the publication here. With David Klantzman, my friend in Paris, conducted a multi-center double-blind study giving IL-2, the regular IL-2, not modified IL-2, to patients with lupus. Besides some logistical problems, I'll share with you that IL-2 was quite effective in decreasing SR6. SR6, a measure of disease activity. I'm sorry, I need to read it here. Patients in remission increased significantly. A number of clinical parameters you can see here improved significantly. The most important thing in this study, though, is that this response was linked directly to the expansion of Treg cells. So he had a mechanism and he had a clinical response to stand on. Now, this is interesting. It was published by our Chinese friends in Beijing. The people, they looked back at the people who had received low-dose IL-2, and they found that these people had lower infections rate. Apparently, the doses that they were given, they were also expanding some effector cells, and these people had decreased rates of infections. So you get a double whammy here, expanding Tregs to control B cells and autoreactive cells, but also expanding some cytotoxic cells to control infections. All right, I already mentioned that. People are trying to modify this to increase avidity for the trimer and decrease avidity for the dimer that's expressed on the effector cells, and also to expand the half-life of IL-2. To give IL-2 to any person, half-life is maximum an hour or 2 hours. Now, let me talk to you a little bit the last 5-10 minutes, and I'll leave time for discussion about CAR T cells and what are they. The concept of CAR T cells was introduced by Zelek Eshar at the Weizmann Institute. I should tell you that he was one of, when I was at the Weizmann, was one of the professors there a couple of years ago. and he published this in 1989. What he did is he took a fab fragment of an antibody recognizing an antigen and fused it with a zeta chain. Zeta chain is important in the transduction of signaling in T cells. Obviously, it had a transmembrane domain, so it can stick on the cell membrane. Right. Later on, this was late 90s by Carl June and others, was expanded in terms of structure, better antigen binding domains, the transmembrane, and inside that, besides the zeta chain, and now they don't use the whole zeta chain, they use only the items, the domains of the zeta chain that are responsible for the signal transduction, and also components of the co-stimulatory molecule CD28 or 41BB. It's here, not the whole molecule, just the domains that are impossible. So when this domain sees an antigen, it delivers signal 1, which is the CD3 TCR, and the co-stimulatory molecule. As interest has expanded, a number of different approaches have been introduced and entertained. One is the bicistronic, which means just introduce two CARs. And in our case, in autoimmune diseases, if you want to suppress B cell responses, you choose a CD19 or CD20, which looks more at most of the B cells, and BCMA, which is expressed by plasma cells or advanced B cells that are going to become plasma cells. So you can target with one bullet the whole spectrum. That's bicistronic. Other people are connecting these antigen recognition domains with the epsilon chain, one of the chains of the CD3 complex. Epsilon chain has this wonderful function capacity to bring together all the other signaling chains, the gamma and the zeta, and deliver the signal. So much more efficient signal transduction. The armored CAR, what is it? It's just the same CAR, but people also introduce a molecule, a vector that codes for protein that's important for the expansion of Treg cells. Would be IL-15, IL-12, or whatever else. For us rheumatologists and other people with immune diseases, this approach here is very important because instead of antigen recognition domain, you fuse here the autoantigen, right? And so this CAR will go if the antigen says double-stranded DNA or histone or one of the lupus antigens, or desmin if you're dealing with pemphigus vulgaris, right? So you put desmin here. So this is going to recognize only the anti-desmin producing cells, B cells, and kill only those and leave the rest of the B cells there. Obviously, as you probably, those of you who are oncologists, you remember Carl June's report in 2012 when he reported a patient with leukemia or lymphoma, I forget, did very well with CAR T cells. In autoimmune diseases, the first effort was taken by Marko Radic. What he did is he made a CAR T cells and took T cells out of two lupus-prone mice, the NGB, NGW, and MRL, expanded them, infused them, and infused them into the mice, and both strains did very well. The people in Erlangen did the same thing and treated 5 patients with lupus. What they did is took T cells from the patients, transfected them with a CAR, CD19 CAR, expanded them, infused them back into the patients. Here are the 5 patients. Here are the amazing clinical responses. And also note here that 3 of the patients don't have very severe disease. Every parameter improved dramatically, as you measured here. Later on, they reported, this was a short period, they expanded that to 8 patients And also they reported that this CAR T-cell treatment was very good for people with inflammatory myositis and systemic sclerosis. All the antibodies that relate to these diseases were suppressed. But interestingly, and for reasons that I don't understand and other people don't understand, is the responses to nominal antigens like tetanus or other good antibodies that we need to protect ourselves from infections are not affected. And that's a big question here, what is going on. Now, there are a few points here that in oncology, the response is there as long as CAR T cells are there. After CAR T cells disappear, the response disappears. Here, all the reports indicate that CAR T cells will go away in 2-3 months, but the clinical effect remains. Mind you, here we have myeloablation, right? And myeloablation with cyclophosphamide and fludarabine eliminates all the immune system only to generate space, homeostatic space for the CAR T cells to expand. Now, the reports so far say mild, and in contrast to oncology, mild cytokine release syndrome, no immune effector cell-associated neurotoxicity, which is a little bit interesting, and no HLH-like syndrome and no low infections. People in oncology report 68% rate of infections. So at that point, when these reports came out, Nature asked me to share my thoughts, and I wrote very politically, but I questioned the importance of myeloablation. The fact that when you transfect cells in vitro, only a third of them get transfected, and we don't know what cells they transfected. Did they transfect CD4, CD8s, double negative cells, Treg cells? Nobody knows. Obviously, the patients were selected. There were undocumented claims about organ damage improvement. And still at that point, it was very short follow-up. I rethought about these issues and concerns, and I organized them here. And first, our concerns about myeloablation. First, to what extent is needed? And second is to what extent myeloablation will have a lasting effect in patients with lupus, right? If you blast somebody with cyclophosphamide, the immune system goes. These people always respond for some time at least, right? The fact that myeloablation is used, it averts the possibility of doing control studies. You cannot do control studies, so you'll never know what is the effect of the CAR T cells. Now, myeloablation will affect also other cells that are important to control of immunity, like will eliminate memory cells and other suppressor cells in the system. Now, there are concerns also about the B cells, because B cells can hide their antigen and expand down the road. Targeting B cells and claiming deep depletion is a little bit problematic, because none of the studies, bone marrows are done or spleen biopsies are done, right? You cannot do it. So you don't know when you say deep depletion of B cells, what do you mean? Deep is 1 centimeter, a meter, a yard, kilometer. What exactly is it? And B cells hide in adipose tissue and other niches around. Now, it is also wrong, the assumption that B cells are driving disease in all patients. Now, and obviously there are other concerns down here. Let me drive you through some concerns that relate specifically to lupus. Now, the mere transfection of T cells in vitro was shown in this beautiful study here that reactivates endogenous viruses. In this case, they found herpes virus 6 being reactive. The simple transfection. Why is this important? Because in lupus, we know, I mentioned already EBV, Andres here has been working on RAB4, a retrovirus that, if reactivated, can contribute to pathogenesis of the disease, and other viruses that we don't know, And you all know that half of our genome, we have borrowed half of our genome from viruses and bacteria anyway. Now, the other thing is uh, people with lymphomas or leukemias that are taken CAR T cells, they develop secondary cancers. And also, there was a few reports, or one report, where a patient developed a CAR T cell lymphoma. Why am I mentioning that? Because I already told you that cytotoxic cells, both CD8 and NK, are decreased in SLE. So these two considerations are very pertinent to patients with lupus. Alternative approaches, briefly. I mentioned already bispecific has been done. Being concerned about the longevity and the cost of the process, people are trying to generate off-self CAR T cells. One of them is the generating CAR T cells from induced pluripotential stem cells. Second approach is generate CAR Treg cells, so you can suppress both T cells and T cells. Allogeneic CAR T cells, just again to have CAR T cells off the shelf. Use mRNA vaccines and a futuristic approach that I will discuss in a moment, right? Bispecific has been already tried in China. It depletes B cells and B cells come back. And I think there's been a clinical report of few patients saying that it works very nicely. Again, the BCMA is expressed late B cells and plasma cells. CAR Tregs, this lady, Holly Rubman, in the lab at DFCI in Boston Children's Hospital, transfects a CAR in Tregs. That CAR sees OX40 ligand in antigen-presenting cells. And by doing so, this engagement activates Tregs and makes them much more potent. She talks also about another mechanism. They tried that in a GVH model and was very, very effective. And right now she's trying it in mice with lupus. Right? She just got a K award, and I'm really excited about that. Allogeneic T cells can use allogeneic, and we avoided graft versus host reaction. These people here, this publication was in Cell, few patients, one with scleroderma, the other with myositis. While transfecting cells, they transfected them with all sorts of silencers for molecules that can cause side effects. So they silence HLA and none of that. So they think that they think they're not going to cause GVH, and they reported here clinical benefit. People in oncology use this concept of immunizing the people with an antigen, RNA vaccine. So you can keep the T cells going on forever. As I already told you that in cancer, at least, CAR T cells work as long as CAR T cells are around, there's a clinical response. So what they're trying to do is expand them. You know, to immune diseases, we have an effect after they're gone. All right. I mean, I already mentioned, I think left you with an impression that cytotoxic responses in patients with lupus are decreased. And these are a bunch of reports here explaining how CD38 suppresses cytotoxic responses. And we thought, and a week later, this report came out, like, while you're making them, you can inhibit molecules that prohibit their expansion. And one of these molecules, CD38. So if during the process of making CAR T cells, you inhibit molecules that inhibit the generation of good CAR T cells, at least in lupus patients, you can have a benefit. Somebody's trying that in the lab for lupus patients now. My friend Morasidian, across the street, will collaborate, published recently in Nature Biotechnology, this quite ingenious approach. He injects the CAR T cells, but then he immunizes the mice, and here uses a tumor model, with a molecule that is recognized by the CAR, this is BCMA, and a mutated IL-2, which will engage the IL-2 receptor and strengthen the response. This approach, he says, you need at least 10 times fewer CAR T cells. Now, there was an editorial linked to this paper. They say, oh, well, why do that? Why don't you put an IL-2 domain within the CAR T cells and avoid this immunization, which I think is important. Making CAR T cells from induced pluripotent stem cells. George Daly, who is the dean of our medical school, published this report claiming that he can make T cells from iPSCs using a methyltransferase 1 inhibitor. And he used that in a melanoma model. It worked very nicely. And now we're trying to, oops, I don't have it here. We collaborate with him to try it in lupus models. The big elephant in the room, the large, I'm about to finish. Okay, sorry, is the cost. And I'm not going to belabor that because other countries can do it much cheaper. In the United States, still very expensive. And this is the futuristic approach. I imagine, and I borrowed that concept, it's not absolutely mine, having a nanoparticle where you put in there your CAR T cell and whatever else you want. You decorate that nanoparticle with a CD8 antibody, and then you infuse it, and then goes into the system and generates CAR T cells in the system without having to take out anything and so on. I think this is my summary here is excitement. I'm excited because we learn a lot of things, but I am concerned and I'd like to dispel spun statements like B-cell depletion, resetting the immune system, what it means, reversal of pathology, depletion of antibodies without affecting normal required responses, and ignoring the effect of myeloablations. And I'll finish with that. Lots of people have been involved in these studies. I've mentioned only a few who have driven concepts. With that, I will finish and thank you for your attention. Unfortunately.
Is there time for a question, Andres?
Can you repeat the question?
Yeah, is it? Yes, if you're looking for me, thank you very much. It's really fascinating talk and exciting times. I'm a nephrologist by trade. I'm just curious if you are aware of any association between immune checkpoint inhibition and CAMK4, given that we see in nephrology a lot more podocytopathy, interstitial nephritis, some of the things that you alluded to earlier when you were talking about lupus nephritis. Are you aware of any association?
Oh, unfortunately, I don't know, but it makes sense to me. And I'm sure if you look at the kidneys, you will have, if not CAMK4, other molecules that are responsible for podocytopathy. And there are many pathways to injure podocytes, as you know. CAMK4 is something we are going by. We study. IL-23 is another one. As you know, as soon as you injure podocytes, they become mobile and they fly away in the urine and you lose them.
Yeah.
But
okay.
It's a point to look into. Thank you.
Yeah, thank you.
Thank you.
Take one picture really quick.
Take a picture with me. Oh. Hey, how are you? Oh my God. Oh, thank you. Thank you. Thank you. Yeah. He's a yeah. For hey, hi. How are you?
How are you?
Good.
It's been a long time.
Right. We defended
we defended the country. And look what's happening now. We left, right? Thank you so much, Dr. Talbot. Appreciate that. Nice to meet you. Oh, hi. Hi. Thank you so much. Thank you. How are you? Right, right, right,
So
right.
I'll let you do
Absolutely.
your thing. I was fascinated by the
Yeah.
CD38.
It's good that you came because he had surgery and
Oh, okay. Yeah.
yeah.
Sorry to hear that. You're recovering.
Yeah, consider the alternative.
That's
I don't like the alternative. Trust me. I'll take any of these.
Yeah,
Yes.
I understand.
So I'm going to stand.
Oh.
You first, and then.
Thank you. You send me one?
Yeah.
All right. Thank you.
My old sweater.
Yes.
Can I be here, please?
Yeah, yeah. Just make me taller a little bit, right? Just 2 feet more.
So where do you want me to come in?
I'll let you know.
Yeah.
Are you available?
I am.
Yeah, so I'll give you a call or text you. Just come on upstairs.
Yeah, eighth floor.
Around
This one,
10 o'clock.